Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center reporting for the week of January 16th, 2023. After an update on COVID, flu, and RSV, I will provide an update on long COVID. As health professionals rooted in Oakland serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Here in Alameda County, we can see that total cases over the previous 14 days continue to decline, although slowly. And we know that this is a significant undercounting because the number of tests being performed per day is also going down significantly. When we look at the percent positivity, we can see that it has come down and it's at 7%, which is good news, particularly at this time, a couple of weeks after holiday mixing. So we're hopeful that this is representative of an actual decline and not just a change in testing behavior. When we look at hospitalizations, we thankfully see that this is also coming down. We now have 115 people in the hospital, 5 of those in the ICU. And looking at our wastewater data, it does also appear to be coming down, although it is possible that with all of our heavy rains and flooding, that the wastewater as a method could be affected. Basically, the amount of rainfall and groundwater could decrease the concentration of SARS-CoV-2 in the wastewater. There is a process that is being used here in California, at least, that helps to account for these things, but we know that it does have some limitations. So just something to keep in mind. And I linked an article about this in case you're interested in more details on this topic. Unfortunately, when we look at daily deaths, those continue to be on the rise nationwide. We're now at an average of 568 deaths from COVID per day, and this amounts to 3,976 per week. So almost 4,000 people dying per week at this time in the United States from COVID-19. When we look at the CDC's forecast or what they think we may be looking at, this forecast predicts that through the remainder of the month of January, we can expect somewhere between 3,000 and 4,000 deaths per week. So we're already there. Hopefully it will remain flat as predicted, but of course, 4,000 people per week is already unfathomable, and we very much need to see this number come down. We look at variant proportions, we can see that XBB.1.5 in the purple continues to be quickly on the rise. It is now comprising 43% of sequenced specimens in the United States. Everything else is on the decline. And remember, we don't like XBB.1.5 because not only does it have similar properties of evading our prior immunity, like the BQs and the regular XBB, that were on the rise before XBB.15 made it on the scene. But XBB.15 has the added feature of binding more tightly to our cells. It binds tightly to the ACE2 receptors on our cells, meaning that it can get into our cells and cause us problems more readily than its predecessors. And I went into some detail on this last week. So clearly XBB.1.5 has a growth advantage, but it still remains to be seen how this will play out. Is it going to mean that people who catch it will get sicker? Will it take over everywhere? How will it compete with other variants that may be circulating in different areas? When we look at the US map, we can see very different pictures across the country with XBB.1.5 again in purple. And if you look at the Northeast, you can see that XBB.1.5 is around 82% of specimens. So really taking over there. But when we look at other parts of the country, including the West Coast, we can see some regions that even have less than 10% of XBB.1.5. And the California region, region 9, is about 16% XBB.1.5. So does this mean that it's on its way here, as we've seen with so many other variants where they start in New York and then make their way over? Or is this a situation where the local variants will somehow keep the new ones out bay or outcompete them? We just don't know that yet. And despite the fact that we're not seeing a big surge yet of XBB.1.5 in California, much of the state is still in the high community transmission zone, Alameda County included. And remember that community transmission is determined by new cases and percent positivity. So overall, we still have some watchful waiting to do over the next several weeks to see how things are looking with COVID in the winter. And unfortunately, although we're still going to keep looking at cases and positivity rates just to see the direction they're going, those are becoming less and less reliable indicators. I remain hopeful that wastewater will be our friend and we'll be able to look at it to see where we're heading. So I'm reassured to see that wastewater is coming down now, but again, the storms and increased rainwater may be confounding that as well. So not ready to breathe any big sigh of relief at the moment just yet. Deaths are the most reliable metric that we have to tell us how we're doing with COVID, but unfortunately, we know that that's a very late indicator, and we know that it's still way too high. We need to do everything we can, which includes making sure folks, especially those who are vulnerable, are up to date on their vaccinations, and that those who should receive outpatient treatment are receiving it. 4,000 deaths per week is way too high. So I will do a brief update on RSV and flu before I get into reviewing long COVID. So both flu and RSV activity are still high for this time of year, but they are declining. RSV is definitely on the decline across the US, and based on our experience of all these prior years of RSV, hopefully that will be it for the season. We don't usually see a second peak, so hopefully RSV is done with us for a while. Flu also is on the decline so far this season through the week ending January 7th, 2023. There have been at least 24 million cases of flu, 260,000 hospitalizations from flu, and 16,000 flu deaths, and 79 of those were among children. So just in that first week of January, that means we had 2 million cases, 30,000 hospitalizations, and 2,000 deaths from flu. Now, unlike RSV, the flu can have kind of another peak in the same season. We usually think of flu season being through March or so. So we're still not out of the woods with flu just yet. So remember, everyone 6 months and up, still a good idea to get that vaccine now if you have not already. And it is well matched to the strains that are circulating this season. So that's good news. So now on to a discussion about long COVID. I've done a couple of deeper dives into long COVID previously, and those are linked in the post if you want additional information. But there was a recent lengthy review published in Nature Reviews Microbiology, and I think it did a really exceptional job of walking us through all the major findings we've had so far from all of the research that's going on right now with long COVID, shines a bit more light on how and why long COVID might be happening, and some recommendations for the future. So if you are interested in this topic, and definitely if you're someone in healthcare treating folks who may have long COVID, this is a really important review that I strongly recommend. It's pretty dense and lengthy, so I will do my best to present here the highlights. One of the biggest challenges I think we've had in trying to understand how much long COVID is happening is different understandings of long COVID, different definitions of long COVID. And I did go through this in a prior briefing that's linked in the post if you're interested. And it's partly because of these different definitions and because it's not a completely well understood phenomenon in general. We know that is being under recognized. And so it's very hard to know what the real burden of long COVID is on society at the moment. The authors here are suggesting, using a very conservative estimate, that about 65 million people worldwide have long COVID. And because there's so many cases that are not documented, this is probably a significant undercount. So we'll say at least 65 million people worldwide. That's pretty staggering. They also did a review of multiple studies and came up with some estimated ranges about long COVID that I think are helpful and I had not seen before. They estimate that among people who were hospitalized with COVID, 50 to 70% have long COVID. And of those who were not hospitalized with COVID, 10 to 30% of those had long COVID. So clearly a heavier burden percentage-wise in those who were hospitalized, but it definitely can happen in anyone who's had COVID, no matter what the severity of their initial COVID infection was. And in fact, the vast majority of long COVID cases are among those who were never hospitalized. So remember, only a small percentage of people who get COVID actually get hospitalized. So this makes sense. But what this means is that the majority of people walking around today with long COVID actually had what we otherwise considered a mild case of COVID. So although COVID does affect all age groups, or long COVID affects all age groups, including children, the highest percentage of diagnoses they found were between those ages 36 to 50 years old. The briefing I did in August on long COVID went into a lot of detail on a study about the potential causes of long COVID. So without going into too much detail here, I'll just touch on some of the theories that still seem to have the most evidence. First is that SARS-CoV-2 is actually persisting in different tissues of the body. So basically, even after you get over the initial COVID illness, the virus is still hanging around in your tissues. Another theory is that the immune system is being dysregulated, or it's just throwing off the immune system. And what some previous studies have shown is that people may have had a dormant virus like herpes virus or Epstein-Barr virus, and those viruses are actually getting reactivated after having COVID. So the immune system seems to be getting thrown off. We don't know for how long. It could be with or without this reactivation of dormant viruses. And there's also mounting evidence that long COVID can be attributed to the fact that COVID affects the gut. The normal healthy bacteria and viruses that are supposed to be living in our GI tract are somehow getting disturbed. And I'll talk a little bit more about that in a minute. And we've also said many times that SARS-CoV-2 affects the blood vessels throughout the entire body. And we've seen that it disrupts the inner lining of blood vessels. It's also causing clots, microclots, and bigger clots. And so it could be that some of these tiny clots are actually what's leading to a number of the different symptoms that people with long COVID are experiencing. So there are other theories in the article, but those are the ones that I think have the most evidence that I wanted to highlight now. And really, they all need more study. But this is an important place to be starting from, because if we understand the mechanisms, or we understand how long COVID is happening, then that will help us understand how to better treat it, or hopefully maybe even prevent it. About a third of people living with long COVID seem to have no identified pre-existing conditions. And what this review did was to take a look across a number of different studies and try to figure out what risk factors there may be for long COVID. And what they found is that those risk factors include being female, having type 2 diabetes, having a history of Epstein-Barr virus. Remember, Epstein-Barr virus, or EBV, is a very common virus. This is the one that causes infectious mononucleosis, or mono. And at some point, we realized that some people, after they get mono, get what's called chronic fatigue syndrome. And I'll get into that in a little bit. There are also some other underlying conditions like attention deficit hyperactivity disorder, different types of allergic conditions, connective tissue conditions that may predispose people to getting long COVID. And they also noted a higher percentage of people getting long COVID who are of Hispanic or Latino heritage, and also folks of lower socioeconomic status. And one of the things that I thought was very striking is that there's a higher incidence of long COVID in those people who are not able to rest adequately in the 2 weeks after they got COVID-19. So this is very important information that may give us some clues on how to prevent long COVID, but needless to say, if you get sick, please rest. Now, one of the first things that we started hearing about when it comes to long COVID was brain fog. I think we heard a lot about that even very early on. And this is what we're now including in what we call cognitive impairment. So cognitive impairment is basically an impairment in your ability to think, to learn, to concentrate or remember, to make decisions, to use good judgment. And the cognitive impairment that we're seeing with long COVID is one of the most concerning features of long COVID. And it is happening at a similar rate, whether the person was hospitalized or not. So it can happen even in milder cases of COVID. And one interesting finding here is that when we measure it objectively, so you go in and you get some kind of a tool or instrument or a screening test done, and the rate is higher when we use an objective tool than if we just ask people about the various symptoms of cognitive impairment. So to me, that suggests a couple things. One is people who have cognitive impairment may not recognize that they have it, and they may not report having it. And secondly, we're going to need some objective tests or tools that we can use that can reliably assess someone's cognitive status after they've had COVID. And ideally, we can do this before they have anything wrong, so we have kind of a baseline of cognitive ability. But I just want to clarify here that this cognitive impairment is separate from any behavioral health conditions, which we also see post-COVID, like anxiety and depression. And I went into a really deep dive on a very large study that was done that looked at over 1 million people who had COVID, and it showed mental health conditions and cognitive impairment. And I went over that in the August briefing. And the most concerning thing I think about that study was that although the depression and anxiety did improve over time and even came back to normal in most cases over time, the increased risk of cognitive impairment, things like dementia, seizures, psychosis, these were all still persisting at the 2-year follow-up mark. So we'll be wanting to see even longer follow-ups from that study, but certainly very concerning that cognitive impairment was persisting even at 2 years. And again, if you want details on that, take a look at the briefing from August 23rd, 2022. Now, I want to spend a couple of minutes talking about a condition called myalgic encephalomyelitis chronic fatigue syndrome, and this is shortened as ME/CFS. And this is an illness that can begin following a viral or bacterial infection. I mentioned Epstein-Barr virus that causes infectious mononucleosis, which we know can lead to ME/CFS, along with other viruses and bacteria that can have this post-viral or post-bacterial syndrome of ME/CFS, which can affect multiple systems in the body. And it results in an inability to basically go back to your levels of activity that you had before you got sick. And this includes work, school, social activities, and even just regular personal activities of daily living. The criteria here is that it persists for at least 6 months, and it's marked by very profound fatigue. So this isn't just, I'm tired, I didn't get enough sleep. This is profound fatigue that's not improved by resting. Includes being really tired after even minimal exertion. Sleeping is not restorative. There can be more of this cognitive impairment, dizziness when standing up or changing positions. So we're seeing this ME/CFS in some percentage of people with long COVID. We don't know what percentages, we're still learning here, but we can tell that there is overlap here, and that the ME/CFS is kind of a subset of folks with long COVID. Now, regarding ME/CFS, 75% of people with ME/CFS cannot work full time. This is very significant. 3/4 can't work full time. And about 25% have a more severe form where they're bedbound, or they're essentially dependent on other people for care. They may need a wheelchair to get around and so forth. And we really don't know why some people get ME/CFS or why some people get severe ME/CFS and others don't get it. So this is obviously a very concerning phenomenon that we really don't understand very well. I have a couple things to say about this. First off, we've known about chronic fatigue syndrome for a long time now, and it just never has really gotten the level of attention that it deserves. According to this article on long COVID, only about 6% of medical schools are even teaching about ME/CFS in a thorough manner. And this is just something that's gone on too long for that to be the case. So I think I hope one silver lining in this is that we're learning a lot more now about ME/CFS. And for those who have been suffering with that for years, decades now, I'm hopeful that all this attention on long COVID and the obvious overlap that we're seeing between long COVID and ME/CFS will result in some breakthroughs and some relief for all of those that have been suffering. Now, one of the most interesting things I found in this review was looking at the GI tract. And it looks like in long COVID, the biome, that normal bacteria and viruses that live in the GI tract, are really thrown off. And this actually looks very similar to what we also see in ME/CFS. So the microbiome of the GI tract of people with ME/CFS and with long COVID, that normal flora in the gut is disturbed. Someone even did a research study where they actually transferred the gut bacteria from patients with long COVID to healthy mice. And these mice actually lost cognitive functioning. It's pretty amazing. And they had some impaired lung defenses as well. So very striking finding in the mouse lab there. We're going to need to learn more about what this equates to in real life, but it is promising, I think, to some extent that we know how to repopulate the GI tract with good bacteria. Hopefully there may be some kind of prebiotic or probiotic regimen that may end up being shown to help long COVID and ME/CFS sufferers. So hopefully there'll be more to come on that area of research soon. So we only have a few years of experience with COVID and long COVID at this point. But what we do understand about the timeline so far is that it looks like the GI symptoms, the respiratory symptoms, the behavioral health symptoms, these are more likely to resolve over time and even come back completely to normal over time. Unfortunately, the symptoms that look more likely to persist or even show up later include joint pain, bone pain, numbness, also the hair loss, visual changes and swelling of the legs and feet and hands. These symptoms appear to be likely to still be present at the 1 year mark, even more likely to be present at the 1 year mark than the 2-month mark. So I think what this underscores is that we just need to be on high alert. If we start having symptoms that we can't otherwise explain, we should try to just see if there's a correlation to tie it back to if there was a prior diagnosis of COVID. And this brings me to one of the major concerns that was highlighted in this review, and I know I've talked about here before, and that is that we need to do a better job of identifying when people actually catch COVID. Well, first off, a lot of the COVID clinics, long COVID clinics, do require a PCR test to even get enrolled into the clinic. So it would help to have proof. Also, in the unfortunate event that you suffer from long COVID to the point where it's disabling, then you would want to have documented proof to substantiate that and to be able to get any kind of disability benefits that you might be entitled to. So without that PCR confirmation, one of the things that was pointed out in this study is that it's actually difficult to even do these long COVID studies because we don't always know 100% for sure if we're including the right people in the right groups. So this is just something we're going to need to get some improved tools, I think, to address. But in the meantime, I would strongly suggest that if you catch COVID, that you actually confirm this with a PCR test. And as far as diagnosing long COVID, this is still a real challenge. We don't really have too much right now other than assessing each problem that a person comes in with or each organ system. So if your heart is racing, we can evaluate your heart. If you have respiratory issues, we can evaluate your lungs. But there are more tools that are in development, which they touched on in the article, including imaging that can help to detect those microclots, different types of microscopes that can be used to look in the eye and see if there's any issues going on there with the small fibers. So maybe we can help understand how COVID is affecting the nerves and other high-tech solutions that hopefully will be forthcoming so that we'll know more about how to actually diagnose long COVID. So in summary, I would say that we are seeing quite a bit of long COVID, and just like acute COVID, it can affect every system in the body. We still have so much to learn. Long COVID does seem to include an overlap with myalgic encephalomyelitis, chronic fatigue syndrome, and it includes impacts on many organ systems, including blood vessel abnormalities, blood clots, and it's already debilitated tens of millions of people. We know in the United States that we have millions less people in the workforce today than we did pre-pandemic, and that is due to a variety of different factors, but one of those factors is a mounting level of disability. So not only are we experiencing a mass mortality event, we are also in the midst of a mass disabling event as well. And of course, this is an event that is still ongoing, 4,000 deaths per week. And so many cases and the potential for so much more long COVID burden. There's also some evidence that each COVID reinfection comes with cumulative risk of impacts on different organ systems in the body, which I reviewed in a prior briefing on reinfections, which is also linked in the post. So we certainly worry that each time you catch COVID, that's another opportunity not only for a bad outcome, but for post-COVID effects, another opportunity for long COVID. So just because you caught COVID before and didn't end up with long COVID, the next time you catch it, you could. So we still absolutely want to encourage avoiding catching SARS-CoV-2. If you or someone you know is experiencing some of the issues like profound fatigue in particular, I think this one is really poorly understood, and it's often just not received well by this, our society that just expects everyone to keep going all the time. But please take it seriously. See your doctor, and if you don't have one, get one, and get all the routine things that we like to check, like anemia, thyroid, and things of that nature to assess, reasons why you might have fatigue. But also let your doctor know if you have a history of COVID and when it was. There's also a resource in the post to finding long COVID clinics near you. And I would encourage that if you think you fall into this category to please check that out. I want to just reiterate something that I said earlier, that there's a higher rate of long COVID among people who did not adequately rest after they caught COVID. And I know I've said this many times here, but if you need it more reason, if you catch COVID, please rest. Take it easy. Give yourself time to recover. Don't rush back out to your pre-COVID activities or activity levels. And if you're feeling fatigued after COVID, don't push yourself. This actually looks like it's correlated with worse outcomes with long COVID. So take it easy, allow yourself time to recover. I know that sometimes it can be easier said than done. We've all got things to do. So ask for help, do what you can to just pace yourself. And if someone you know is experiencing these things, please believe them. Please don't dismiss it. We know that long COVID can be debilitating. And the last thing we need to be doing is dismissing what someone is experiencing, because that can really compound what is very real. So the bottom line is we still want to prevent getting COVID. If you've gotten it before, let's not get it again. And we know how to do that, starting off with our high quality filtration masks. These are your best bet, because it doesn't matter if it's BQ or XBB or what variant it is. A filtration mask is going to reduce the risk of you catching COVID. Indoor air quality, absolutely critical to reducing spread. You need good ventilation, good filtration, which you can assess with a CO2 monitor. But also, if you're in an indoor space with people outside your bubble, you're really going to be relying on that high quality mask. And limit your time in there. Don't linger too long. We know about vaccination and staying up to date on your boosters, particularly those who are vulnerable. Please encourage them to get caught up with the bivalent booster. Remember that we have also very good outpatient treatments for SARS-CoV-2. Anyone else who gets hospitalized or dies from COVID, we really need to be asking, was this person given appropriate treatment as an outpatient? There are very few reasons why people who are at risk of a bad outcome should be denied treatment. We have a few options here, and it is just a rare exception of someone that actually can't take any of these. So yes, you may need to hold a medication in order to take Paxlovid, but that's okay. So make a treatment plan now before you get sick. And remember, if you don't have a primary care provider, please get one you like, get one you'll go to see, get one you trust. If it's not the one you have now, change, and know how to reach out to them before you need them. Make sure to stock up on rapid tests. These tests are definitely not perfect, but they are a good layer of protection, and they're even more helpful when you repeat them over time. Remember to order your free test from the US government, and remember to confirm it with a PCR, especially if you don't feel well and you're someone who would be treated if you're positive. Also, if you're positive and you need that documentation to prove it. And please do what you can to avoid getting infected or reinfected. And as always, remember to eat a balanced, nutritious diet, get some exercise, unless you're sick with COVID or fatigued post-COVID. In that case, get your rest, manage your stress levels, consider a multivitamin supplement with additional vitamin D, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.